Haere mai, ko Auraki toku maunga, ko Waimakariri te awa, no Afrika ki te tonga ho, engari e noho ana o te tahi. Tēnā koutou. Good afternoon, I'm Ashleigh, and I just acknowledge the lands of Aotearoa, New Zealand, where I grew up on, and also First Nations people in Australia, where this research was conducted, and also the First Nations people here, whose lands we've been able to share lots of knowledge and stories on for the last 2 days. So thank you for having me. I'm a PhD student of Sharon's, and my background is medicine and pediatrics. I snuck in to present, so I feel very grateful because it's my first conference. And best of all, get a standing ovation, no matter how bad it goes. So thank you. Our research is focusing on the lessons for the next global crisis. And there is only one slide with numbers because it's qualitative. We were exploring migrant families and Australian-born women's experiences of pregnancy, birth in the first 12 years postnatally during the pandemic. And as much as we would love to move on from COVID, as one of my participants said, how to go back, because a lot of people don't even know where to start. And I think she captures what the other migrant women in this research is saying, is that they're still living with the ongoing long-term impacts of the pandemic. But also, COVID brought about a lot of natural, rapid experiments in the social determinants of health. And so we have this rare window of opportunity to learn what matters to health when we disrupt the social determinants, and how can we do better with the inevitable next time. So Australia is particularly well placed for research focusing on determinants of health during the pandemic, and that's because, as Sharon mentioned, we had one of the most locked down cities in the world. We had these prolonged public health restrictions, but as a result we had very little COVID virus initially, and we actually increased our life expectancy during the pandemic. And then 1 million women gave birth during the pandemic in Australia, and understandably the COVID policies occurred without their consultation because of the nature of crisis, but we now have this opportunity to highlight their voices. So we did a qualitative systematic review in Australia to find out what interviews had already been done, and 8 studies were found, but because of the pandemic and recruitment difficulties, they generally recruited women on social media. So once again, we have research with very low demographic diversity. So Australia is actually very diverse. So 1 in 3 women give birth, who give birth there, from overseas, and most come from India. And pre-pandemic, they had inequitable health outcomes. And we also know that they are frequently excluded from our planned clinical health guidelines and from policy reforms. So we decided to focus on migrant women predominantly from the Western Health region of Melbourne, which is a high migrant area and has about 1.2 million people living there. So I intentionally spent a couple of months driving in my car to recruit women in person through health hubs, immunisation clinics, libraries, shopping centres, just anywhere where people are generally quite hard to reach, but to try get a lower SES and non-English speaking women in our study. We did 60-minute semi-structured interviews, and we analysed the data using reflexive thematic analysis within a pragmatist paradigm. And for the Punjabi speaking women, we used a community-based participatory research design. So that's where the community are involved in the research design and implementation. So Karen Deep is a community researcher. She also has lived experience of being an Indian migrant mother to Australia, and she runs a Punjabi playgroup for the early years in the Western Health region. So she was employed for this research to bridge the gap and have meaningful and safe inclusion of the Punjabi community. And it wasn't just consultation. We have been co-facilitating the recruitment, the interviews, data collection and data analysis together. And having her made such a difference with instant trust of these women, and they were able to communicate their experiences in their mother tongue. We also had Laura, who is very experienced in this type of research, and she's actually got a really awesome resource about community-based participatory research, if you want to look that up further. So alongside CRCHUM, we also had a community advisory group, and their role was to meet with us regularly and guide each stage of the research to ensure that it was relevant and meaningful and safe. And we had 7 Punjabi women meet with us regularly with this group. So overall, we recruited 31 women, which in qualitative terms is a lot. 13 were from Australia and 18 were born overseas. A third were first-time mums and a third had not been to university. So we're still in data analysis comparison phase, but I just wanted to give you the 3 themes that have come up focusing on migrant women. The first being a silent mental health pandemic. And migrant women spoke of being alone. Pretty much all of their partners were essential workers, most commonly truck drivers. And whilst this was great for having a consistent income during the pandemic, the burden of childcare fell on these women. And despite childcare being free for essential workers, they did not take this opportunity because they were fearful of the virus, and culturally as well, they just preferred to look after their child themselves. Which is completely understandable, but it did mean further social isolation of their child. We heard a lot about their children experiencing social anxiety, and it also meant no respite for the mum. And unlike Josie's Pakistani families who lived in multi-generational households, these women tended to just live with their immediate family because they were first-generation migrants. Women also spoke of feeling afraid. And you can imagine being a first-time mum, doesn't speak the language of the country you're in, learning all the new skills of breastfeeding whilst in isolation. There was also a consistent experience of maternal health services not caring about the mother's health, but being hyper-focused on the infant. And as a result, none of the Punjabi women were screened for postnatal depression, despite this being a requirement at 4 weeks postpartum. Nearly all of the Punjabi women also spoke about experiencing postnatal depression for months to years and the stigma of disclosing postnatal depression. And without even prompting them during the interviews, some took that opportunity to talk about it for the very first time after not even telling their partners due to the stigma. The second preliminary theme was West and East is not the same, they have different treatments. And this quote is referring to the inequitable distribution of our so-called universal maternal and child health service. And it's a great example of a policy that has unintentional adverse effects. So in March 2020, there was this COBRA policy implemented where maternal child health services were told to prioritise 0 to 8 week-olds, preference telehealth consultations, reduce their appointments to under 15 minutes, which is just like barbaric when you think of meeting a first-time mum and their newborn for their first home visit. And then also only seeing infants over 8 weeks old if the workforce allowed, and that was at the discretion of the health provider. So this meant that in places where maternal child health services were completely overrun, infants missed out on 60% of their recommended well-child checkups before school. And the migrant women in these locations reflected on this, saying that their child, now 3 years of age, has not seen a maternal child health nurse since they were 2 months, and we're in 2023. Every time we called maternal child health, they were like, no, they didn't have the capacity to see anything other than a newborn right now. Lots of families out this way that are disadvantaged financially, socioeconomically, they could be missing big developmental things. Maternal child health appointments were delayed. I started to notice my child, who's 3, not progressing as he should. He wasn't talking, he wasn't playing with the other kids, he was isolated. And the speech delay came up with almost all of the migrant families. Unlike Josie's Pakistani families as well, where this was lessened with the multi-generational households, once again, these families were just in their immediate household in their bubble. I don't know if it's like racism or discrimination or they do it on purpose. I pay the same tax. And so the places that maternal child health services had low capacity to see infants over 8 weeks are also the most common places for Indian migrant communities to live in Melbourne. So we've got this pre-pandemic statistic where in Australia, kids who spoke a language other than English were already more likely to be developmentally vulnerable in one or more domains. So we have a vulnerable group pre-pandemic who are missed for the developmental screening before they start school. And the biggest issue is that they still continue to be missed, even though acute phase of the pandemic is considered over. And the last theme is I'm afraid to go to the public hospital, and this captures migrant women's mistrust in predominantly an English-speaking health system, which probably existed pre-pandemic but was exacerbated by COVID. So firstly, they didn't understand the English health information that was given to them about COVID vaccines or even just about routine antenatal care. They also didn't feel listened to or that they could advocate in the public system. And there was a lot of talk about next time, if I can afford it, I want to go private. Unlike the doctors they experienced in Australia, they felt that their doctors back in India listened to them and had more time to explain things to them. And as a result, many of them actually did return back to India in 2023 when borders opened to seek health advice about their child who now had speech delay or social anxiety. So when we compare this to Australian-born women, just really briefly, they had the ability to mobilise and mitigate pandemic adversities because of their social privilege and financial privilege. So they were able to pay for quicker healthcare through the private system so that they could see a paediatrician if they were worried about their child's speech delay. They had connections generally to health professionals through their family or friends that they could just pick up the phone and call a nurse. They knew that actually you could get an exemption so that multiple households could combine in one bubble for childcare. And them and their partners usually had jobs that they could do from home so they could share the childcare. So what to do going forward, and this is as suggested by those mums, we need to play catch up, especially because these kids have missed their first 1,000 days of life. Before the next pandemic, we need to make sure that our maternal child health services, which are our prevention and early detection services, can withstand things like pandemics and continue to provide high quality, timely access. Oh, sorry. And just lastly, we need to build trust because there's no point having a health system if people don't trust it. And we need to inform our high-risk groups of policies that would support them during pandemic. Great, thank you so much.